Good morning. My name is Amanda Zylak, and I'm here to do a transfusion medicine educational session for Kipling and Mooseman. Always, we just want to remind everyone of SHA's vision, mission, values, and philosophy of care. We acknowledge that we are gathering on treaties 2, 4, 5, 6, 8, and 10, the territories of and the homeland of the Dakota, Lakota, and Métis people. Transfusion safety and patient blood management. Who are we? My name is Amanda Zylak. I am new to this role as of September. Prior to this, I was an MLT in transfusion medicine for 14 years. I have a counterpart in the north named Kimberly Goodwill, and we work very closely together to support the whole province. So if I'm ever unavailable, please call her or Jennifer Lambert. I will give you their contact information at the end. Jennifer Lambert runs the Regina Transfusion Medicine Department. Her staff do all the complex transfusion testing for southern Saskatchewan, and they send compatible blood to the rurals. Kim and my roles as the transfusion safety managers for the province is to support all of you and promote safe, effective, and standardized transfusion practices across the province. This has been neglected for far too long, as we all know, and we are working on making our processes better and safer for our patients across the province. So there's a big push in the transfusions world right now called patient blood management, and it is an evidence-based multidisciplinary approach to optimizing the care of patients who might need a blood transfusion. It focuses on improving outcomes by optimizing the patient's own red cells, such as treating anemia before surgery, minimizing blood loss and bleeding through surgical anesthetic and laboratory best practices, and finding patients' true hemoglobin thresholds, so only transfusing when absolutely required. The goal of PBM is to ensure that patients receive the right care at the right time with the least amount of exposure to donor blood, thereby improving safety, conserving resources, and reducing cost. Part of our portfolio is also the IG Stewardship Program. This program monitors and ensures the appropriate use of IVIG. IVIG is $67 per gram, and some patients are on doses as high as 200 grams. Some patients will be on IG for their lifetime, so it's the job of the IG program to taper patients' doses to the lowest possible dose that actually works for that patient. So transfusion safety. In Canada, every part of the laboratory is regulated by Health Canada, and that's especially true in transfusion services and the blood products we manage. Because of these regulations, we are required to maintain a vein-to-vein traceability. In simple terms, that means that we must be able to trace back every blood product or component from the donor all the way to the patient, including every step in between. So storage, transport, modification, and final infusion. Hospitals must keep permanent records of which blood products were issued to which patient and when. These records are kept indefinitely to meet national safety and traceability requirements. All of our labs are accredited by the WCAA, with the exception of Regina, who holds CAP accreditation, which means that they are even more rigorous standards applied there. None of the rules we're going to talk about today are arbitrary. They're all based on national and international standards designed to ensure that every patient receiving transfusion gets the safest possible product. So all blood components are manufactured by Canadian Blood Services and collected by volunteer donations. So blood components are separated parts of the whole blood. So they include red blood cells, platelets, plasma, and cryoprecipitate. Blood products are mostly purchased by CBS from vendors. So blood products are made by fractionating plasma proteins. They include things like albumin, IVIG, fibrinogen concentrate, and coagulation factors. So blood component basics. So the whole blood donation can be broken down into three main components: packed cells, plasma, and platelets. So there's another component called cryoprecipitate, but Canadian Blood Services can only make cryoprecipitate or platelets. So platelets are so much more useful, especially when there is a product called fibrinogen concentrate that works the same, if not better, and it's a safer product. So Most places are very much moving away from cryoprecipitate and just using fibrinogen concentrate. A typical red blood cell unit issued by Canadian Blood Services is approximately 287 mils. 1 unit of red blood cells usually increases the hemoglobin by approximately 10 grams per liter in a 70 kg non-bleeding adult. Blood samples collected from the donor at the time of donation are tested against certain transfusion transmissible infectious agents. A big topic lately is vaccines. CBS does not make their donors disclose if they have been vaccinated. So if a client does not want vaccinated blood, there is actually no way of finding out that information. Red blood cells are stored at 1 to 6 degrees. So Mousseline and Kipling, you guys don't store plasma or platelets, so this is going to just be for your awareness. Plasma has mostly been replaced in the province by a product called Octaplasma. It is produced by Octapharma. It is plasma, but it is more processed, so we get the same benefits of plasma, but it is a safer product. So platelets, pooled Sorlin treated, so they are pooled from multiple donors of the same blood group, and apheresis Sorlin treated platelets are produced from single donor apheresis platelet donations. Each dose of platelets should increase a patient's platelet count at 1 hour by an increment of 15 in a 70 kg adult. Some disease states can decrease the amount of an increment, such as sepsis or fever. Platelets are stored at 20 to 24 degrees. All blood products and components must be visually inspected upon receipt, at the time of issue, and at the time of infusion. CBS's visual inspection tool is an educational resource meant to inform the user about the visual variability of blood components and its causes. So the link is right there, and it takes you right to the Canadian Blood Services website. The picture on the slide shows the variation of color between two normal packed red blood cells. So here are some problems, examples of problems that for red blood cells. So the first example, there's a clot. The second example is bacterial contamination. So the unit will look completely black. The third, there's some cellular aggregates in there, and then white particulate matter and hemolysis. So if any of these things are seen in a unit, do not transfuse it, call Canadian Blood Services, send it back to the lab. It needs to be documented. Fractionation products such as albumin or IgG, the product should not be cloudy, the lot number should be legible, and the safety seal should be intact. This is just an overview of what a CBS label looks like, and most important for nursing to know is about the donation number. Is at the top corner and the bottom sticker. This number will be the number you verify on your report and your transfusions tag, the blood group of the unit, and the expiry date of the unit. So ABO blood group systems. ABO blood group system is our main category. So you can think about it like the most important and the most basic way to categorize blood. So we sort people into 4 big groups: Group O, Group A, Group B, and Group AB. Each group is based on the antigens on the surface of the red blood cell. So you can see above that Group A has A antigens on the red cell surface and anti-B antibodies in the plasma. Whereas Group O has no antigens on the red cell surface, but has anti-A and anti-B in the plasma. So why is this important? If you give a Group O person a Group A donor unit of red blood cells, the anti-A that is naturally occurring in the Group O patient's plasma will bind to the donor cell and cause the donor cell units to hemolyze. But ABO is not the only complexity when it comes to blood compatibility. There are subcategory blood group systems. So there are over 30 blood group systems that we test for in transfusion medicine. So just because a person is O positive, it does not mean that any unit of O positive blood is compatible. Patients develop antibodies to these other blood group systems by transfusion of donor red cells, pregnancy, and sometimes they are naturally occurring. So sometimes it's just easier to understand when you see it a different way. So here's a couple different depictions of basic compatibility charts. So if a patient has a negative antibody screen, meaning we aren't detecting any of those other 30 blood group systems antibodies in their plasma, these units, these are the units that they would be compatible with. So you can see that O positive can receive O positive or O negative, but O negative can only receive O negative. A patient who is AB positive, however, can receive all blood types. This is why O negative is the universal red cell donor and AB positive is the universal red cell recipient. O positive is the most prevalent blood group in our Canadian demographic, followed by A positive. Here's just another diagram to show basic compatibility if a patient's antibody screen is negative. So I have said that O negative is the universal donor, but Kipling keeps O positive on hand as their unmatched unit of blood. Why? O negative is in high demand across the country, so we don't want to deplete the country's stock by unnecessarily transfusing it or outdating it. Only 7% of the population is O negative, so we want to save it for those patients who truly need it. So the patients that can only receive Rh negative blood are patients who are Rh negative, patients with an anti-D, women of childbearing age receiving unmatched blood, pediatrics, which is defined as less than 17 years old, receiving unmatched blood. O positive is safe for most emergency unmatched situations. If we give an O positive unit to someone who is Rh negative, they won't hemolyze like they would if a group A unit was given to a group O person. This is because we do not naturally have anti-D in our plasma. Anti-D is the antibody against Rh positive blood. So what happens if a patient, what can happen is a patient can develop an anti-D later on, which means they would no longer be able to receive Rh positive blood in the future. But this antibody can also cause very serious clinical problems in pregnancies. It's called hemolytic disease of the newborn. D. Anti-D is not naturally occurring and can only be developed when an Rh negative patient is exposed to Rh positive blood. This can only happen through pregnancy and through a red blood cell transfusion. So why is developing an anti-D a problem? So it causes hemolytic disease of the fetal newborn in subsequent pregnancies. So this is why we give Winrow to Rh negative mothers, and it's so important to prevent the development of an anti-D. And it can complicate future red blood cell transfusions. That being said, just because a patient is Rh negative and they receive Rh positive blood, it doesn't mean that they will definitely develop an anti-D. Whether someone forms antibodies depends on their immune system. Some people are just more immunogenic than others. However, there is always a real possibility that an anti-D could develop, and if it does, it can create complications in the future transfusions and future pregnancies. This is why we avoid giving unmatched blood unless it's truly a life or death emergency. In those critical moments, saving the patient's life takes priority, but the long-term risks still matter once the immediate crisis has passed. Transfusions in Canada are extremely safe, largely because Health Canada holds us to such high standards. The statistics on this slide show the chances of contracting disease through transfusions are incredibly low. But the number I want to draw your attention to is the risk of giving a patient an ABO incompatible unit is about 1 in 350,000. So that might seem rare, but it's actually quite high when you consider that 1 unit incompatible red cells can be fatal, and that the main cause of ABO incompatible transfusions is patient identification errors. So these can happen at any step, during collection, by the phlebotomist, during testing in the lab, issuing the unit, or at bedside when the unit is being hung. So this is exactly why we have such a strict policy requiring 2 nurse patient identification and proper bedside checks. It's also why transfusion samples across the province require a second independently collected sample for a confirmatory blood grouping. I'll talk about that later. A simple demographic mismatch can be deadly, and a risk of 1 in 350,000 is still far too common for something that is human error and completely preventable. Cross-match, group and antibody screen, group and screen, and type and screen are all synonyms. The sample requirements for a group and screen are 3 EDTA tubes. Please note that if a patient has an antibody, we do need lots of sample to do the antibody ID, so please always try to send full tubes so there's not a delay when waiting for more sample. A cross-match is valid for 14 days if a patient has not been transfused red blood cells or pregnant in the last 3 months. If a patient has been transfused red blood cells or has been pregnant in the last 3 months, their cross-match is only good for 4 days from time of collection. As we talked about before, both red blood cell transfusion and pregnancy can stimulate the immune system, and the patient may develop a new antibody. Hence why we do not transfuse red blood cells without a current antibody screen. Without appropriate testing, transfusing a patient that has developed a clinically significant antibody can cause a serious transfusion reaction. This is the rec you will be using when you're referring testing to Regina. It can be found on the SAS Blood website under the Forms tab. Check off the type and screen if you are requiring blood products sent back out to your site. Please always call Regina and let them know you are sending a sample and expecting units back out. If Regina does not ask, please ask if the patient requires a confirmatory blood group. Labeling requirements for transfusions samples are the same across the board. They always require full first and last name spelled correctly, HSN or MRN, date of birth, initials of the collector, and a TSIN. The TSIN stickers are a unique set of numbers that can only be used once for a single antibody screen sample collection. They can never be reused. The TSIN sticker must be placed on the patient's armband, and the armband must stay on the patient from the time of collection to the completion of the transfusion. The sticker links that group and screen sample to the patient's arm and the cross-match testing done on the specific sample. The collector's initials must be on the tube, and the requisition must be signed and dated by the collector. If any of this information is missing or illegible, the sample will be rejected and it will need to be recollected. There are no exceptions when it comes to transfusion samples and no relabeling. A confirmatory blood group is collected to reduce the risk of ABO mistransfusions in patients who do not have a historic blood group or transfusion record on file. If a patient has a historical blood group on file from anywhere in Saskatchewan, this can be looked up on the eHealth viewer, and a confirmatory blood group does not need to be collected. Without a second independently collected sample, errors such as misidentification at the time of collection could go undetected and lead to the wrong blood type being transfused. We understand that this is not always feasible in a small center to have a second person do the confirmatory collection. In that case, you do not have a second person available, it is the same person can leave the room, come back, and re-identify the patient and collect a second time. We understand that it seems silly, but unfortunately, this is a transfusion standard that nobody is exempt from. Its purpose is to ensure that the right blood goes to the right patient, and it provides a second identity check and prevents patients from the most preventable and most dangerous transfusion-related errors. At the end of the day, it is always about our patient safety. The same requisition is used. You can check off confirmatory ABO. Only one EDTA lavender tube is required for a confirmatory blood group. Labeling requirements are the same for all transfusion samples with the exception of the red TSIN sticker. As we said before, the TSIN sticker is attached to the antibody screen, not to the blood group. When shipping samples to the general, please put the confirmatory sample and requisition in a separate bag. How to fill out a TM requisition. The yellow boxes must be filled out by a nurse, physician, or unit clerk based on the physician's orders. These boxes are not to be filled out by the lab personnel. Here is a properly filled out requisition. The addressograph must have all the same information as the sample labeling requirements. The physician ordering and transfusing facility with a contact number. This box gives a brief history and clinical picture of what is going on with the patient. Previous transfusions and pregnancies is in case there is a possibility the patient has developed an antibody. This information also changes the outdate of the antibody screen. The historical blood group tells us if we need a confirmatory blood group collected. Request details informs Regina of what testing to do and if you require blood products backed out to your facility. This bottom box is to be signed by the person who filled out the requisition prior to the sample being collected. This box is to be filled out by the person collecting. There must be a date and a time and 2 healthcare professional initials. The patient must be identified by 2 individuals for all transfusion samples. For a group and antibody screen, the TSIN sticker goes in the appropriate box. The referring laboratory is the middleman. If for a transfusion laboratory, write that here. If you are going to ship directly and receive from the site, it is not necessary to write that twice. If you require blood to be sent out to your facility, someone must call RGH Transfusions at this number. Acceptable versus unacceptable. So we have our patient name and information here. This first sample is unacceptable because it is illegible. This sample is missing the date of birth. This sample looks okay, but the first name is spelled incorrectly. The date of birth is in 2025 and it is missing a TSIN. This sample is missing a TSIN. So this is what we get most from rural facilities is the underlabeling. So all transfusion samples must be labeled completely at patient's bedside. So if you have a patient and you just write their name and then you run down to the lab and you put the sticker on, it will be rejected. Regina will peel back all of your labels. So if you want to use a label, print the label and then bring the label with you, do the collection and use the label. If you are going to manually label at bedside and you do not have the sticker available, you must put the whole requirements. So the first name, last name, HSN, MRN, date of birth, TSIN, and your initials on the tubes for it to be accepted. So this is a properly labeled tube. So it has the full first name and last name spelled correctly, the HSN or the MRN, the date of birth, the TSIN number, and the collector's initials on the tubes. Remember that transfusion samples can never be relabeled or have missing information. Any sample that is illegible, mislabeled, or underlabeled incorrectly will be rejected and will need to be recollected. So here is your new procedural changes for your Credo coolers. You will now be transfusing from the Credo coolers always. Samples will be sent to the lab will package them up and send them to Regina with the courier, and the units will be sent back with the courier or by stat cab if required. If a stat cab is required, it will have to be approved by the Regina hematopathologist on call. The Credo will come to you packed like this with a safety seal. The Credo coolers keep the packed cells between 1 and 6 degrees for 72 hours, and they are validated annually. So since it is kept between 1 and 6 degrees, it's as if it has never left RGH's fridge. The temperature for transport is between 1 and 10 degrees. These boxes will never make it to 10 degrees in 72 hours. Since you are not opening the cooler until you are ready to transfuse, there will no longer be a data logger inside. Just to note, we also have Credo boxes validated for platelets if that was ever required. This is the updated flowchart for receipt and transfusion of blood in rural facilities. I have printed and laminated 3 copies for your site, and I have emailed them to your managers so they can upload them to wherever you guys keep your SOPs until the new provincial system is up and running. This is what the top of your Credo coolers will look like. From now on, there will only ever be 1 unit of blood in each Credo cooler. If you're receiving 2 units of blood, you will receive 2 coolers, 1 unit each. and one of the coolers will say open first. If you're receiving multiple patients on the same day, the patient's HSN will be written on the top of the cooler somewhere. The credo that is indicated open first will have all the necessary paperwork inside. On the top of the cooler, you will find this green sheet of paper. It indicates the date and time the unit is valid until while inside the sealed container. Inside the credo box, you will find a patient blood bank report, SHA blood products issue voucher for rural facilities form, a request to issue blood and blood components form, and the notification of administration of blood and/or blood products form. This is the product issue form. The top of this form will be filled out by RGHTML. The yellow portion of this form must be filled out by the healthcare professional opening and/or the healthcare professional transfusing the unit. The 3 boxes must be checked off: that the tamper-proof tie was intact when you received the shipping container, that the blood for transfusion has passed visual inspection, and that there was a blood bank report. Signature that and date and time that the box was open, and signature date and time that the box was hung. All of this must be filled out, faxed back to RGH, and photocopy the form and apply it to the patient's chart, and then send the original back in the credo box to Regina. This is the request to issue form. It will come with a unit number sticker in the top corner here. The healthcare provider is expected to fill out the rest of it and fax it back to RGH. RGH's fax number is on both of these forms. This is the patient notification form. This form stays on the patient's chart until discharge, and at discharge, the patient must sign that they have been notified that they have received human blood products during this stay. This form does not need to be faxed back to RGH or sent back to the lab. This form was put in place in response to the 1993 Crever Commission for patients who did not know that they were transfused and received blood products that were infected with HIV and hepatitis C. Blood administration. Upon hire, all staff participating in transfusions must complete the administration of blood components and blood products Module 1 and Module 2. The administration of blood components and blood products Module 2 and the handling and transporting of blood must also be done annually. For every transfusion of blood components or blood products, a transfusion administration record, a TAR, is required. The TAR must be filled out at the time of transfusion. This is what the TAR looks like, and it can be found on the SHA website under Clinical Forms and Catalog, or on the SAS Blood website under the Forms tab. It is the responsibility of the healthcare provider transfusing to confirm that the appropriate patient information is at the top of both pages of the TAR. Blood products or components from the lab or opening the Credo cooler, please ensure that you have copies of informed consent, patient identification is attached to the patient, written physician transfusion orders, a blood group and antibody screen has been completed, dedicated IV line access, baseline vitals must be completed and documented within 30 minutes of transfusion. We know that in smaller centers, the patients are not always wearing identification armbands, but if you are transfusing blood components or blood products, it is mandatory that a patient be wearing a patient identification armband. Opening the Credo cooler. The cooler must come zip tie safety sealed upon receipt. Confirm that the unit inside is for the correct patient by looking at the paperwork once opened. Prior to infusing, informed consent for the transfusion must be obtained. It is not the responsibility of the nurse to obtain consent. It is the responsibility of the physician or the nurse practitioner. It is their responsibility to make sure that the patient is aware of the material risks, nature and consequences, benefits, And the person must also be made aware of reasonable alternatives, including the consequences of refusing blood products and components. These risks include the fact that any blood product or component obtained from human sources may contain unknown agents that may transmit disease. The discussion must be documented on the informed consent form. It is the nurse or the transfusionist's responsibility to ensure that the consent is on the chart and signed prior to hanging the unit. Consent must be obtained once per hospital stay, except for in treatments like IVIG, where the consent is only required once per year, as long as the diagnosis and treatment plan have remained the same. This link can be found on the Blood Administration Clinical Standard, and it is a great resource for patients and families who have any questions about blood transfusions. This is an informed consent form for our QHR, and here is the informed consent form for former Sun Country. Picking up blood products from the lab. A transfusion pickup slip is always required when picking up any product or component from the lab. This slip can be a requisition or a piece of paper with the appropriate information on it. There's going to be a provincial transfusion request pickup slip document created at some point, but we don't have a date on that yet. The slip must contain the recipient's first and last name, date of birth, and a unique identifier such as the HSN, the recipient's location, the component or product type requested, the volume, quantity, or dose required. These pickup slips must be retained for 5 years. A visual inspection of the component or product must be performed by the technologist prior to issuing. The technologist and staff picking up the product or component must confirm that all the patient identification from the request slip matches the component or product, and the component or product matches the tag. This can be done by one person reading off the logbook and the other person following on the unit and tag. Issue of the component or product must be documented in the transfusion logbook. The logbook must be signed by the technologist and the staff picking up the product. By signing the logbook, you are taking responsibility that you have completed all these steps. After hours, 2 healthcare providers must complete the previous steps prior to the component or blood product leaving the lab. Bedside pre-transfusion checks must be done at the bedside in the presence of the patient. Checks must be done and documented on the TAR by 2 qualified healthcare professionals. Patient must verbally confirm their identity. If the patient is nonverbal, a family member or another healthcare provider can do this step. Patient identifiers must be identical on the blood bank report, patient armband, and the component or product tag. Confirm that the correct patient ID is at the top of the transfusion administration record form. And if transfusing a component, you must verify the ABO and RH compatibility by referring to the blood bank report. Confirm all the unit or lot numbers match on the unit or vial to the transfusion's tag. Perform a visual inspection and confirm the expiry date. Each healthcare provider must sign the TAR. If there are any discrepancies, do not transfuse. Call the laboratory or the tech on call and return the unit to the lab immediately. If the packed cell was from Regina, call Regina TML at this phone number. Completing your pre-checks, attach the pink copy or the duplicate copy of the transfusion tag to the TAR. A copy of the transfusion tag must be attached to the unit for the entire transfusion. Blood component and product monographs. What are they and where to find them? The product monographs have all the information that you could possibly need to know about each product or component, from the description to indications to dosage to administration to adverse events. Where can they be found? They can be found on the SAS Blood website. Under each product or component, there's a link to the monograph, or on the SHA website, you can search transfusion medicine and it'll take you to this page, or search blood or product monograph and resources. Patient monitoring. Transfusion of blood components must be completed within 4 hours from time of removal from a temperature-controlled environment. Therefore, they must be infused within 4 hours of opening the Credo or 4 hours from time of issue in the lab. Standards say that you have 60 minutes to spike the unit once it leaves cold storage, but you have to remember that now you only have 3 hours to transfuse that unit. So be mindful, and it is always our suggestion not to open the cooler or go pick up the unit until you are ready to transfuse. Administration of blood products such as albumin must be completed within 4 hours of accessing the product vial. If 4 hours has elapsed and the transfusion is not complete, the transfusion must be discontinued and the remaining blood component or blood products must be discarded. We always start our infusion slowly for the first 15 minutes, so 50 mils per hour, and then increase as tolerated to the MRP ordered infusion rate. All patients should have their vital signs checked within 30 minutes prior to initiating the transfusion, 15 minutes after blood exposure. So the 15 minutes that we're starting slowly infusing shouldn't start until there's actual blood exposure. So don't start that 15 minutes at a slower rate until when the line is still priming. Every 60 minutes until the transfusion is complete, within 15 to 30 minutes after completing the transfusion, or as clinically indicated if there is some sort of symptom or a reaction. All this being said, there is still always a chance of a delayed transfusion reaction. So we want to make sure that our patients or anybody who is taking over our patients are aware that there are signs and symptoms to be watching for the next several hours. Post-transfusion, flush the tubing with normal saline to clear the line or between consecutive units. Disconnect the infusion set and discard. Plug the open port on the blood bag to prevent leaking. Document the completion of the transfusion on the TAR. Do not discard the transfused blood bag. It is important to keep the unit for 12 hours post-transfusion in the event of a delayed transfusion reaction. Place the red blood cell unit bag in a bag and place it back in the Credo with the original issue voucher form and send it back to Regina. Transfusion reactions. Report everything. Transfusion reactions across Canada are wildly underreported. Why? Mainly because most transfusion reactions look like other common clinical issues. Symptoms such as fever, hypotension, tachycardia, respiratory distress, nausea, rigors, rash can all be attributed to many disease states. There are lots of gaps in education or inconsistent training. Staff may be unaware of what qualifies as a reportable reaction or believe only serious or obvious reactions need to be reported. They may underestimate mild or delayed reactions, such as taco or a mild allergic reaction. Delayed and subtle reactions are often easily missed. Maybe they don't transfuse often enough to see the symptoms. Reporting feels time consuming. They have fear of blame or consequence that they did something wrong, or the belief that the patient is fine, so it does not matter. Please report everything. Algorithm will be on the back side of the issue voucher in the Credo cooler, and it can also be found on SHA's website under Blood Administration Resources, Clinical Resources. There's also many more resources on the SAS Blood website under Transfusion Adverse Events page. Signs and symptoms of transfusion reactions. Fever, mild reactions include fever and chills greater than 1 degree of a temperature or a temperature greater than 38. Also, the feeling of being cold or chills should be monitored for up to 4 hours post-transfusion. Skin reactions, allergic symptoms, restlessness and anxiety. This is one that gets missed a lot. If a patient has a general feeling that something is wrong, stop the transfusion. It is commonly missed just because people don't believe the patient, but the patient knows if something is wrong. Headaches, those are often associated with IVIG. More severe reactions, breathing problems, pain, gastrointestinal distress, cardiovascular issues. Some less common but very serious signs are changes in urine. Darker reddish urine can mean hemolysis, bleeding, abnormal or heavy bleeding from the IV site or elsewhere, or neurological changes, dizziness, restlessness, confusion, are all transfusion reaction symptoms. If you have a transfusion reaction, what do? Stop the transfusion immediately. Start a new line of saline and keep the vein open. Take vital signs, including temperature. Ensure the patient is comfortable and start oxygen if required. Recheck the patient ID and blood product. This is probably missed most often. Notify the ordering physician and the transfusion medicine department. Do not continue the transfusion or disconnect the unit unless directed. It is the responsibility of the physician to decide if it is an adverse event. The physician may direct you to continue the transfusion after administering medications such as Tylenol or Benadryl. This is okay, but the reaction is still reportable. So if you stopped, treated, and finished the transfusion, the reaction can still be reported on a TARE form. If the reaction is severe, always call the TMP on call. Administer the drugs as ordered. Complete the Saskatchewan Transfusion Adverse Events Report Form, the TARE form, not to be confused with the TAR. This form can be found on the SHA website, on the Transfusion Medicine homepage, or on the SAS Blood website under Forms. You must collect a post-transfusion reaction sample. It will be 2 lavender EDTA tubes, and they must be labeled the same as a regular transfusion sample. For transfusion reactions in non-testing sites, you send everything to Regina General Transfusions Department. Page 1 of the TARE form, the blood component, unit, or product vial, the post-transfusion sample, and the nursing notes from the transfusion. This is the SAS TARE form. It is 3 pages long. The first page must be completed by the healthcare provider completing the transfusion. The healthcare provider is responsible for completing every section on the first page and putting the patient addressograph on all 3 pages before sending it to the lab. After completion, send the SAS TARE form, the post-transfusion sample, the implicated unit or vial, and the nursing notes from the transfusion reaction to RGH for testing and hematopathologist review. And here's my sales pitch. Please join my committee. The SHA Integrated Service Area Transfusion Utilization and Safety Interdisciplinary Committee. What is it? The ISA TUSIC is a multidisciplinary transfusion committee required under accreditation standards. It brings together physicians, nurses, laboratory staff, and leadership to oversee and support safe, appropriate, and effective transfusion practices within each integrated service area. Why we need it. The committee ensures high-quality patient care by promoting best practice in transfusion medicine and patient blood management, auditing how blood components and products are used, reviewing transfusion reactions and errors, and implementing corrective actions. It also develops and shares policies and educational materials, supports alternatives to transfusion, and serves as the local emergency blood management committee during blood shortages. This structure ensures accountability, consistent standards, and clear communication across the province. This committee is not optional. It is an accreditation requirement, and several of our rural sites are now being cited for not having active physician participation. If we cannot secure volunteers from your facilities, we risk losing the ability to transfuse blood in our smaller centers, which means the patients will need to travel farther from their homes for care. Your participation directly protects the local access to safe transfusion services. Very much, and if you have any questions, feel free to call or email any of those phone numbers or emails on that last page here. Thank you for your time.